We appear before you as a people, Lord, asking for mercy, even by the blood of Jesus. We pray that, Father, our gathering here also will be successful. And knowing that without you we cannot do this, we ask for your Holy Spirit to help us in our deliberations, Lord. That, Father, at the end of the day, the purpose for which GSS is called, O Lord, will be fulfilled. We ask that, Father, the decisions we will take here will be seasoned by your Holy Spirit, and we'll be able to have good plans to, Father, perfect the work that we've been asked to do. In the mighty name of Jesus, and everyone will say amen.
Amen. Thank you so much, Mr. Bessa. A round of applause for him, please. Ladies and gentlemen, I will start by introducing members of the high table who are gently seated in front of us today. At the far right end, ladies and gentlemen, we are blessed to have the Associate Professor at the University of Ghana Business School, Professor Patrick Asumin. A wave, please, for us to see Prof. Next to Professor Asumin, we are blessed to have the UNICEF representative who happens to be a health specialist, Mr. Paul Henry Jani Edu. Thank you so much for coming. So I would skip and move to the gentleman in the white and black African batik, who is a gynecologist, ladies and gentlemen. He's a gynecologist with the Ghana Health Service, Dr. Athanasius Ayeti Levy. Next to him is the acting deputy statistician, Mr. Edward Isiu Afram. And we'll move to the leader of the Ghana Statistical Service, ladies and gentlemen, I and yours, government statistician, Professor Samuel Kobna Eni. Thank you so much, ladies and gentlemen, for coming. Some few housekeeping. Let's kindly keep our phones on silence or on vibration, not to interact the forum for this morning, so we can hurry up and leave here and attend to other equally important activities lined up for the day. We have about 3 exits here, one to your left, so that's my left, one to the right, and one at the back. In case you would want to use any of the restrooms, they are right behind you. You can kindly excuse yourself and make sure you are comfortable before you come back to join us. Today promises to be very brief, yet very intensive and very educative. Ladies and gentlemen, the UN Sustainable Development Goals has been very clear on when it comes to maternal health and adolescent risky sexual behavior. Today we are going to be releasing 2 thematic reports that is focusing on the utilization of maternal healthcare services and adolescent risky sexual behavior, with focus on the methodology used, that is the small area estimation reports. So that's the small area estimation methodology which was used for this particular report. And the report is focusing or deriving or leveraging on the Ghana Demographic Health Survey, which was carried out in 2022 after the 2021 population and housing census. And as the UN Sustainable Development Goals have indicated, Goal 3, Target 3 to be specific, we talked about health. It has its focus on good health and well-being, that's reducing global maternal mortality ratio to less than 70 per 100,000 live births by 2030. Ladies and gentlemen, we are just 5 years to 2030. And how are we faring? What are we doing? What are the plus and minuses that needs to be considered to ensure that policies are churned out to ensure that nothing but the best is achieved when it comes to accessing maternal health care services? Also talking about adolescent risky sexual behavior, The UN Sustainable Development Goals is also emphatic on it, and it combines a number of the goals. You talk about Goal 2, which has to do with hunger. You talk about Goal 3, which has to do with mental health and substance abuse, because immediately you talk about adolescent risky sexual behavior. One thing that readily comes to mind has to do with substance abuse, violence, and unsafe sex. SDG 16 also talks about violence perpetration, which all inculcates into this. When you narrow it down to Ghana, in 2008, you and I were in Ghana. If you were not in Ghana, you may have heard wherever you were around the globe that in 2008, then President John Agyekum Kufuor introduced a free maternal health care policy within the National Health Insurance Scheme. Although these policies in place, it's been fraught with a lot of challenges. How do we deal with these challenges if we don't have data? That is where the Ghana Statistical Service comes into the picture, and that is what they have done today, to tell us the findings at the district level, because the Ghana Demographic Health Survey at the time in 2022 dealt at the regional level. So this particular report that will be released today, which are two, what has to do with utilization of maternal health care services and adolescent risky sexual behavior, will give us details about their findings, what needs to be done to ensure that targeted interventions will be taken to those at the district levels who need these interventions the most. Without much ado, ladies and gentlemen, I would go ahead and invite the government statistician on whose shoulders all these rest, Professor Samuel Kobina Ining, to formally welcome us to today's forum. A round of applause for him, please. Please keep the applause coming.
Now, is it okay if I just remain here?
Because of the cameras, they would prefer you being here, please. Please keep the applause coming to encourage Prof to get to the podium.
Thank you very much, Na, and I really appreciate the detailed background context that you've provided for today's engagement. Distinguished ladies and gentlemen, good morning. Just as Na did, I always want my feedback just like Na. Distinguished ladies and gentlemen, good morning. Good morning. Thank you very much. So on behalf of the management and the entire staff of Ghana Statistical Service, it's my privilege to formally welcome you to today's release on two thematic areas, as Na indicated, one focusing on the utilization of maternal health care services and the other focusing on adolescent risky sexual behaviors. Na, as I said, has given us a very good background in terms of the issues. What I want to do as part of my welcome remark, which my colleague Peter will do in a bit more detail, is to give you how we've done things in the past, why we've done them, and going forward, how we are changing what we are doing as a service. Anytime we are embarking on a nationally representative survey, we are guided as a service by two things. One is the coverage, and the other is the representativity of the coverage. So what I mean by coverage here is that you make sure you cover your 16 administrative regions, and there is a flexibility on asking yourself whether you want to cover all the 261 administrative districts or otherwise. This has cost implications. This leaves burden on our respondents as well. So traditionally as a service, we've done our statistics, putting out national aggregated figures, and at the disaggregated level, that is the granular statistics, we do it up to the 16 administrative regions. As I indicated, we've not been able to mobilize enough resources to make sure that the coverage that we have, one, would cover all the 261 administrative districts. And even if you cover all the 261 administrative districts, the key question is whether the sample that you have in each of the 261 administrative districts will be representative enough to enable you generalize and make statistics that characterizes the entire district. In as much as financial constraints and burden on respondents has constrained us in getting to the 261 administrative districts, with the evolution around analytical methods, now as a service, we are able to generate statistics at the district level. So anytime we do a census, which gives us the base, and following from the census, we do any survey, and we meet that simple criteria that at least a respondent should come from each of our 261 administrative districts. The analytical approach that we are using today enables us to calculate whatever phenomena that we have at the district level. We are so excited about today's release, not just because of the issues, but the timeliness of it. Colleagues, there are a number of things that are going to happen in the next few months. We have a new government that has its own policies, is yet to implement the policies. So one of the reasons why we are doing this today is at the minimum provide the new government with baseline data for policies that are yet to be implemented. The other reason why we are doing this is that there are some policies that have been existent that we need to continue to monitor, some policies that we're going to design freshly, and some policies that we're going to redirect. Today's statistics will provide us that platform for government to think through how we redirect these statistics, how we do targeting differently to ensure that, one, we don't leave no one behind, and we cover through the coverage of all our 261 administrative districts. The third reason why we are excited about this is that there are ongoing monitoring efforts. I just spoke to my colleague from Ghana Health Service about Ghana's own medium-term health sector plan, which runs out at the end of 2025. We believe that this gives us a platform to continue with the monitoring exercise, but more importantly, before Ghana Health Service embarks on a follow-up, a successor to the existing health sector medium-term plan, there will be basis for the Ghana Health Service to say that we can evaluate what we've done over the period of the health sector medium-term plan that we've been running as a country. So for these four reasons, we are very excited that this is very timely and is going to support the work of government. The other issue that we want to highlight going forward with today's discussion is our ability to relate data that we collected in 2021 and data that we collected in 2022. Most of the time, we've had to argue out why that data is still relevant. There's a good reason why the global community says that censuses should be done decennially. And one of the reasons is that the issues that we're going to talk about today borders on behavior. They have behavioral issues. And you all would agree with me that it takes time for behaviors to change. So in as much as the baseline data is 2021, and the data that we are estimating from is 2022, adolescent risky sexual behavior takes time for change in behavior to occur. If you do not utilize healthcare services, it's a behavioral issue. So in as much as we align with the fact that the data is 2 years ago, 4 years ago, it's still relevant because of the issues that we are dealing with that do not change rapidly over time. Our efforts in providing government with the needed data as it starts its policy rollout would be further deepened because in the next 1 month, that is in the month of February, other reports in these areas that we're going to put out include childhood immunization, exclusive breastfeeding, safe disposal of children's tools. We'll touch on domestic violence, as now indicated, cancer screening, hand washing and water treatment policies, alcohol use, women empowerment, and lastly, unmet need for family planning. So between now and the end of the month of February, there are other 10 reports that would leverage the census data and the Ghana Health and the demographic survey to help us understand these social and health issues that affect our day-to-day activities. So on that note, thank you very much for making time for this engagement, and going forward, we hope that you would help us advocate on how to use statistics to influence policy rather than limiting it to only monitoring interventions. Thank you very much.
Please let's do better for government statistician, Professor Samuel Kobina-Enin. Indeed, data plays a very key and important role if we are to develop as a nation. and the global community as well. Prof did mention about some of the burdens or challenges that they are encountered with in trying to mobilize data. Ladies and gentlemen, next on the bill, we will take a statement from one of our key partners in lifting some of these burdens when it comes to gathering data to ensure that development is driven and it is continuous. Our rep is from UNICEF, is a health specialist. Ladies and gentlemen, help me welcome Mr. Paul Henry Jan Adu for a brief remark from UNICEF. Please, let's keep the applause coming.
Now, before Paul speaks, he's not just a key partner, but this work is not only a technical collaboration between UNICEF and Ghana Statistical Service, but UNICEF actually provided the financial resources for this exercise.
Fantastic. A round of applause to that.
Hello, good morning. Thank you, Mr. Chair, and I wish to say that I'm making this speech on behalf of our country director or UNICEF representative and the government statistician and Professor Samuel Kobina Enim, senior management and directors of the Ghana Statistical Service, regional and district coordinating directors, regional and district health directors, developmental partners, civil society organizations, distinguished guests, ladies and gentlemen. It is an honor to join you today for the dissemination of these important thematic reports from the 2022 Ghana Demographic and Health Survey, DHS. Now, these reports represent a vital step in our collective efforts to improve the lives of children, families, and communities across Ghana. First and foremost, I would like to commend the Ghana Statistical Service for leading this effort to generate high-quality data that informs policy and programming. When the government statistician spoke, he mentioned how that coverage, representativeness, and timeliness all define how important this data set is. At UNICEF, we believe that relevant, quality, and timely data is more than numbers. It is a tool for change. Data helps us understand the challenges children face, guides the development of effective policies, and ensures that resources reach those who need them most. The 2022 DHS report, which was released last year, indicates that vaccination coverage of children aged 12 to 23 months against basic antigens has actually decreased from 77% in 2014 to 73% in 2022. This decline leaves many children vulnerable to preventable diseases such as measles and polio. It also suggests potential barriers such as reduced access to healthcare services, vaccine supply challenges, or growing vaccine hesitancy, especially in underserved areas. Although anemia among children 6 to 59 months has reduced from 66% recorded in 2014 to 49% in 2022 nationally, it is still high and very prevalent in northern Ghana to up to 69%. Additionally, the percentage of women aged 15 to 19 years who have ever been pregnant has increased from 14% in 2014 to 15% in 2022. This rise in teenage pregnancy can limit educational and economic opportunities for young women, increase maternal and child health risk, and perpetuate poverty cycles. Today's dissemination is not only a testament to the power of evidence, but also a call to action for all of us to use this information to drive meaningful change. The health, nutrition, water, sanitation, hygiene, and protection. They illuminate persistent inequities and highlight areas where investments are urgently needed. For example, the health and nutrition reports provide critical insights into maternal health services, identifying gaps in antenatal care, skilled delivery, postnatal care, and also emphasize the need to address malnutrition and improve access to essential health services for all children. The reports on water, sanitation, and hygiene also shed light on the level of access to clean water and proper sanitation facilities across Ghana. They identify areas where communities lack these basic services, leading to poor health and outcomes and increased vulnerability to diseases such as cholera and diarrhea. In the Child Protection Report, the data underscores the need for robust systems to safeguard children in Ghana from violence, exploitation, and harmful practices. These findings, Mr. Chair, are both a reflection of progress and a reminder of the work ahead of us. Achieving the SDGs and Ghana's development targets requires us to act with urgency and purpose. And as we digest the evidence presented today, let us ask ourselves critical questions. Number one, how can we strengthen partnerships to ensure that no child and adolescent in Ghana is left behind? What innovative solutions can we adopt to tackle the challenges highlighted in these reports? And number three, how do we ensure that the voices of children, especially the most vulnerable, inform our policies and programs? UNICEF remains committed to support the government of Ghana and all partners in translating this data into action, whether through policy advocacy, capacity building, or community engagement. We stand ready to collaborate in ensuring every child in Ghana has opportunities to survive, thrive, and reach their full potential. In light of this, it is crucial to continue our efforts in statistical modernization, data quality assurance framework, building human capacity, and supporting evidence generation. I would like to extend my sincere gratitude to all those who contributed to the production of these reports, the writers, editors, reviewers, and all stakeholders whose dedication has brought us this critical resource. Special thanks to all partners for their commitment to advancing the rights and well-being of children in Ghana. In conclusion, Mr. Chairman, I encourage all of us to view these thematic reports not just as documents, but as a roadmap for action. Let us leverage this evidence to build a brighter, more equitable future for every child in Ghana. Thank you, and I look forward to our continued collaboration.
Please keep the applause coming. Thank you so much, Mr. Jani, for those few words which are energizing and are reassuring and encouraging, engaging all of us and in asking us to ensure that we're strengthening our partnerships as individuals, as a nation, and as institutions, ensuring that no one is left behind, and ensuring that the voices of young people, which is so important, are heard. We will be zooming in straight into the presentations, and there will be an opportunity for questions to be asked both online and those joining us in person. How did these reports come about? We would be inviting to the podium a data scientist with the Ghana Statistical Service who will be bringing us an introduction to the methodology used. That's the small area estimation methodology. Ladies and gentlemen, with a round of applause, help me welcome Mr. Peter Mwinlaru. A round of applause for him. Mr. Peter, did I get the pronunciation of your surname right? Thank you.
Thank you very much for the opportunity. Good morning. Yes, so as have been said by Prof. and the earlier speakers, we all know that we are here for releases of 2 reports. And we are told that these reports are small area estimation reports. So I am here to just lay a foundation to how the various statistics that were generated for these reports were arrived at, as in the methods that were used at generating those statistics. That is what I'm here to do. Then they will come and do the proper presentations. So it is always expected, or it is encouraged, that countries like Ghana always try to present statistics or data in smaller geographical units, i.e. like districts, instead of presenting them at national, like national statistics, one figure, mortality rate for Ghana, you put it there, or at the regional levels. The reason being that if you're able to provide statistics or produce statistics at smaller geographical units, then there are some benefits that come with it. Number one, it helps government to be able to bring targeted interventions. Apart from government, all development partners, anybody who wants to bring intervention to the country is able to target specific areas these interventions are supposed to go to. This is because statistics at district levels helps you know the districts the problems are, so that the interventions that are meant to solve those problems are sent to those specific problems that the district the problems are, and not sent to any other district where that intervention might not be needed. Also, this helps us to be able to assess the impact of policy interventions. So Ghana and countries have been having policies. So Ghana, you have a number of policies, all aim at solving a particular problem. And if these policies are enacted, how do we know whether we are achieving our policy targets? We are able to do this if you're able to get statistics at lower levels, so that first you get to know where the issues were, then over time, as you continue producing these statistics at those lower levels, you get to know the progress you are making in either achieving those policy targets or the effect it's having. So if the interventions are not having the necessary impact, then you have to revise them to then give them the necessary support to give us the impact we need. Also, statistics at lower levels help us to monitor key indicators. So we all know that there are a number of indicators which are very important in measuring how well we are doing in all sectors of our economy. So in health, we have indicators, we have economic indicators, and a number of indicators. How do we monitor these indicators? It is when you produce statistics at lower levels. That is where you're able to monitor to see whether the indicators are improving or they are standstill. In that case, then policy is supposed to change to help improve the indicators we are getting. And if you're able to monitor these indicators, it helps us to influence evidence-based policy and also help us enhance our planning as a nation. All that I've said means that as a country, we are supposed to delve into all the data sources we have in the smaller, or all the organizations or MDs. You have to delve into them and try to use this data to produce statistics at smaller units, like district levels, to be able to get these benefits of what I've outlined. So it's always important to get statistics at lower levels instead of leaving them at more aggregated or higher levels. So with this background, then why are we saying we are using small area estimation? So there are two things or two scenarios happening here. In mostly statistical organizations like GSS and some organizations, we conduct surveys. Then GSS, as Prof mentioned, also conduct censuses. But censuses are conducted every 10 years, while surveys are conducted in between two census periods. There are some advantages that come with the census. The advantage is that for censuses, you are able to cover the whole country. So you're able to visit everybody and get information. So we get a view, a very proper view of what is happening across the country. But because of the size of the people, in terms of the number of people you are going to visit, and the cost involved, you are not able to collect information that can help you measure all the important indicators we need as a country. You're able to measure some, while you are not able to measure what? The others. So census are able to give us data every part of the country, and therefore you can get data at the smaller geographical levels like districts. So you can get information that if you use this information and analyze it, you can get an idea of what is happening in every district. But as I said, we are not able to measure data, all the important indicators we need from census data because of the cost and the volume of work involved. But the survey data is able to give us mostly the detailed information we want. So in survey data, we have a lot of important indicators we're able to collect data on. But because of the volume of the questionnaire, and the cost involved, we are also not able to go to everywhere. That means we sample and go to certain parts of the country, or in a particular district, we go to certain places and leave other places out. So survey gives us the detailed information we want to measure the important indicators. But this data we are collecting are not representative at the district level. They are not representative at the district level. While census are representative at the district level, but you are not able to get all the questions that will help us measure all the important indicators. So this is a problem. This is a problem. So in this case, that means if you want to get statistics from survey data, you can only do that. If you want to use the data itself alone to do that, you can only do that either to get statistics at the national level and at the regional level. You can't get it at the district level. So there is this method that can help us bridge this gap. That can help us get lower level statistics like districts using survey data. And this method is what we call the small area estimation. So small area estimation, there are some techniques that we use. And in this technique, in using it, you need to combine both the census data, that is give us the lower level disaggregation, and the survey data, that is give us the important indicators. You combine these two using certain techniques to be able to estimate the survey indicator, the important ones, that will be representative and more meaningful at the district level. So that is all that small area estimation is about, and that is what we use for this kind of report. So to illustrate that, I'm showing these three maps. The first map on your left is giving us, this is for the DHS, that particular map. We are showing the sample. So in the DHS, we collect data from households. So we are showing you the number of households we collected data from every district in Ghana. And if you look at it carefully, there are some districts we have 0. If you look at the legend, the first figure there is 0. And you can see that within the map, we have some white spaces. That means there are some districts we didn't collect data from at all. While there are districts we are collecting only like data from only one household or up to 4. So what I'm trying to say here is that in some districts you don't go there, whilst in others, even when you go, the sample sizes are what? Small, so they are not representative at the district level. So that is what that map shows. Now let's look at these two maps, the other two maps. The first one gives us statistics. So you are representing the percent of the population with no education. And these two were done using the census. So you're able to get what is happening within the regions. Then the same thing, but you get to know what is happening within the districts. If you look at these two maps carefully, you can see that in certain regions, example like Ashanti, Eastern, Greater Accra, Central, where it is showing us that there are less than 8% of the populations in these areas that have no education. But if you go to the district level, you see that in some districts, the story is not like that. In some districts, we have as high as 24 to 43% happening. But if you aggregate and generate the statistics at the regional level, because it is at a bigger group, some districts mask the information in the districts where the problems are. So if you lose the regional estimates, you would think that all is well with regions like Ashanti, Eastern, Greater Accra, and Central compared to the other regions. But when you come to the district estimates, you're able to see that it is not all that rosy. There are certain places that need still some intervention because the problem is still there in those districts. So this map helps us know the reason why, or the most important reason why we are supposed to get estimates at district levels. So if you only have it at regional levels, some information is masked. And therefore, you might think some places, like some regions, all the districts there, they are doing well, so you don't have to go there. But when you use the district estimates, they're able to see exactly where the people are doing well and the places where interventions are are needed. So it's always very important to get statistics at lower levels, like districts. But as I said, with this problem, with the one on the first map, we are not able to get these direct estimates from survey data. So that is why small area estimation is very important, to be able to bridge that gap and get us something like this, so that you get to know where the problems are and solve them. So that is what the methods we use, and these methods give us the statistics that the other presenters will be presenting on. Thank you very much.
Thank you so much, Mr. Peter Munlari. A round of applause for him before he gets to his seat, ladies and gentlemen. So as we have been briefed on the methodology used, that's a small area estimation methodology, we would be taking the various presentations on the maternal healthcare services utilization, as well as that of the adolescent risky sexual behavior, after which we would give an opportunity for questions to be asked. But I would want to inform you that right after the presentations, we would be taking some brief remarks from one of our key international partners from the UNFPA. But at this juncture, ladies and gentlemen, help me with a round of applause. Welcome Dr. Kobna Abaka Ansa with the Ghana Statistical Service. He will be giving us a presentation on maternal healthcare services utilization.
Thank you very much. Good morning, ladies and gentlemen. And let me stand on the existing protocols to take us through the report on the utilization of maternal health care services in Ghana. And as Peter rightly said, we combined the two data sources to produce this report. So we will look at the outline, we will talk briefly about the background of the work, and then go through the measurement of the indicators through up to inequalities and some correlations that we performed. Now, by way of background, we all know that if mothers utilize maternal health services, there's a likelihood that we're going to reduce mortality and morbidity for the mothers. But the World Health Organization has also indicated that by the year 2030, we expect maternal mortality ratio to be reduced as much as possible to 70 per 100,000 live births. What that simply means is that if mothers give birth, the number of deaths as a result of the delivery should just be 70 per 100,000 women. Now, the MC even mentioned some interventions that have been introduced and being implemented by the Ghana Health Service and other agencies in Ghana just to ensure that we are able to reach this mark. And we have listed some of the policies that we are implementing as far as this is concerned. And we can see we have the free maternal health care policy that was introduced in 2008. Then we have the community-based health planning systems, that's the CHIPS, emergency obstetric and newborn care, national reproductive health policy, then standard treatment guidelines for maternal health, which was also introduced in 2014, and the last one is, as we can see, if you run through all the policies, the main aim is to ensure that we are able to reduce maternal mortality as possible, the lowest level. Nobody will be happy that your relative goes to deliver and then you are told that the person has passed. It is something nobody wants to hear. And so all these policies are geared towards that we record the lowest numbers as much as possible. Now, with what Peter said, the statistics on utilization of maternal health services in Ghana from the Ghana Demographic and Health Survey is at the national and regional levels. So how do we know what is happening at the district level? And so as he said, the combination of the two data sets, that is the 2021 PAC and then the 2022 Demographic and Health Survey, will allow us to see what the districts are doing with respect to the maternal health services, as we have indicated here. And so we may all say that we have some statistics at the district level, but what we have there are administrative data. It is when people report that information is picked on this. But if you want to get population-based data on this, then the only means by which you can do that is from the census. That is why the census comes in handy. And the combination of two methods will give us district-level statistics to tell us where the interventions must be sent to. For the purposes of this presentation or report, we focus on two of the maternal health services indicators. One, the antenatal care, and then the facility delivery. By that, what we mean is that where do people go and give birth or deliver? Now let's look at the measurement of indicators. We want to just go through some brief definitions of the terms as being used here. The first one that we can look or can think about is the ANC, which refers to a medical care received by a pregnant woman from a skilled provider, including a doctor, a nurse, a midwife, a community health worker during pregnancy. Then we also try to look at the definition as espoused by the 2022 DHS. And the other one is facility delivery, which refers to where the birth occurs in the facilities that we have mentioned. And then postnatal care, the services that the mothers will receive after they've given birth, and we are told it occurs just 48 hours after birth. And then utilization of this service refers to having a minimum of 4 antenatal care visits. So if somebody receives anything less than 4, it is not recognized. We expect that the person should have a minimum of 4. Then we will conclude that the person has received antenatal care. So let's look at the spatial dimensions of these indicators. Here again, we have employed the services of the map to tell us where these services are taking place. And so this is in respect of women 15 to 49, that is those who are in the reproductive age. And so the first map on my left looks at the percentage of women 15 to 49 years who had the minimum, that is the 4+ ANC visits by district. As we said, the DHS has given us information at the regional level as well as the national. What is the situation at the district? So we have delved deep into the district. And so if you look at the map, you can see that districts in Upper East and Upper West are doing very well when it comes to ANC visits. And they are having as high as 95% and above. Then when you come down, we can see that we have some districts in Bono, and then we come to Volta, which are also doing well, between 90 to 94%. But then most districts within Northern Region, Savannah, Bono East, and I think Western North, the numbers there are very low. And so if hitherto we have indicated that ANC coverage is high in these regions, what is the situation in the district? So these are some of the lessons we need to pick from this. Then on my right, we present something on the same reproductive age group who delivered in a health facility. The expectation is that if the person assesses the ANC services, obviously we expect him to go and deliver in a health facility. But is that the case in the district? So again, Upper East still tops the league. And it is not surprising because the number of persons that receive the ANC services is still high, 95 and above. And then when you come to those who delivered in a health facility, the percentage is still high. We are referring to districts within the Upper East region. The Upper West, the number has dwindled. In the previous map or chart, you could see that almost all the districts in the Upper West the women access ANC. But when it comes to where they deliver, the numbers have changed from that high to 90 to 94%. And then Ahafo down there in the previous chart, we could see that the number that access ANC services was not that high. But when it comes to delivery, the situation has changed. We have some districts in some regions, for example, the northern region, which has less than 75% of their women delivering in any health facility for that matter. Now we combine the two, the ANC and then the facility delivery, to see the composite. What will be the situation? That is, after the person has accessed ANC services and has delivered. So we now look at this. And this is the district estimate of composite utilization of maternal health care services. And so with the two combined, we still see that the Upper East is still leading with 75% and above. Now the number has reduced from the original 95, which simply means that some persons who access ANC services and also delivered, the number in a health facility has gone down. That is the composite. But when you come down, you see regions like Ahafo, which you saw in the previous map, which was also doing well when it came to ANC services, and then places that they deliver. Still it is high with about 70 to 74%. We have some districts in some regions. Example, the northern region, northeast, and then you can come to Oti. The numbers are so low, less than 45% of the women. Now let's look at the district ranking. As we said from the beginning, the whole exercise is to let us know where these things are happening, irrespective of the region in question. The region is doing well, but what about the district? So we now want to look at what is happening in the various districts across the regions. In doing that, we have ranked the top 10 and bottom 10 districts. That is utilization of the maternal health care services in Ghana. And so on my extreme right, we also introduce the distance to the nearest health facility. Not facility, the nearest. Somebody can be in Accra and may decide to access it in Koforidua. That is the person's own issue. But this one, we're talking about the one that is nearer to the person. Assuming that is where you want to go. And so we have some distances as low as 0.9 kilometers. And we have as high as 5.3 kilometers. Let me just place on record that this is just one variable. There can be other reasons. This is just one of them. Why, for example, Karaga is having a figure of 72.7 with a distance, a minimum distance of 5.3 kilometers. It does not mean that that is the only contributory factor. There can be other reasons. But if you look at the ranking, if you cast your minds back, we saw in the previous slides that the Upper West and Upper East were doing well when it comes to ANC and then facility for delivery. And so it is not surprising that when we did the ranking for ANC, the one municipal tops in the Upper West region and is the highest for Ghana with as high as 96.8%. And then districts within the Upper East are following, which is just in conformity of what we saw in the previous slide. But if you do the bottom 10, we have Northeast, that is Mamprugu, Manduri, performing better in that ranking than a district like Oti, Nkwanta North, with as low as 70.4. What that simply means is that if you look at the ANC services by women in these regions and the districts that we have listed, this is how the districts are performing. So if there are any interventions, we don't just go and say that the Upper East is doing well. Let us look at which districts are lagging behind and then send our interventions. We went ahead to look at the same top 10 and bottom and up for the facility delivery. Where do these women deliver? Here again, we did the same thing by doing the ranking. And a district in the Upper East, in fact, the top 10 districts are all from the Upper East. From Bolga Municipal up to Talensi, with 97.5 up to 94.9. And with the lower 10 districts, it is topped by Uti, with Krachi in Chumuru being the highest with 61.0%, with as low as 51.8 for the Miao in the northern region. And as I said in my previous statement, the distances are not the only factors that are accounting for this. It could be one of them, but there can be other factors that are responsible. Now we combine the two, that's the composite. And the situation is not too different from what we saw, with the exception of some regions or districts in the previous chart that were not performing very well when it came to the ANC and the facility for delivery. But with the composite, we've seen that it is still led by the Bolga Municipal, but we have some districts in the eastern region coming into the picture. So if you look at the top 10, we have the Bogatanga Municipal leading the lake with 84.0, and then Ebuakwa North Municipal with 79.7. That is the top 10. So Ebuakwa North is the 10th in that lake. But when we consider the bottom 10, it is led by Karaga. We saw that the nearest distance, yes, to the time to get to the nearest facility is 5.3 kilometers, and it is showing here. But we have said that that may not be the only cause for this. There can be other variables that we have to consider. And that one, we have a district in Savannah, that is Northeast Gonja, with the least percentage of 42.3. Now let's look at some regional distributions of these indicators. What we did here was that we tried to use the interquartile range to look at the variation or the deviation of these indicators from the region. You know, we are talking about the district. So how wide is the district away from the region? So if the region is doing that well, are all the districts within the region performing the same? And this is how we have presented it. So if the range is that wide or big, what it means is that district in that region, the particular indicator, for example, the ANC, the spread is wide away from what is happening within the region. So the region can be doing well, but the district within the region, the variation is that wide. And so we did a ranking of this. And so for the regions, if you take Northeast, you see it has the highest of 7.4. What that means is that districts in that region, if you look at the ANC services, the variation between what is happening at the regional level and the district level is that wide. But if you come to Ahafo, it has 0.5. What that simply means is that the variation between the regional estimate and the district estimate is not that wide. So it's the same thing that we have done for the facility for delivery, the same pattern. So where we have the high numbers, signifying that the difference or the variation or the deviation from the region is that wide. But if the number is that close, it means more people within the district or the region are accessing the facility. So that one, we have the Northeast with the highest of 12.3, and then the least is still with the Ahafo region. Now we also went ahead to do the composite, and the explanation is similar or is the same. So what this simply means is that if you combine the two services, ANC and then facility delivery, this is the picture. So in the Northeast, the variation is that wide. Districts that are accessing the services, if you compare that one with the region, the situation is wider apart. And it is still least in the Ahafo region. Now we look at some inequalities and some correlations. And here what we did was that we tried to look at the inequality within the region and then between regions. So if you take maternal health services within the 24.2 is if in the within the region, what is the inequality gap? Is just 24.2. But if you want to compare that region with another region, the gap is as high as 75.8. If you come to facility delivery, the same story is being told here. Within the region, within a particular region, the inequality is 27.4 within the region. But if you want to compare that one with another region, the gap is 72.6. And the same thing for the ANC visits. The last one that we did is the correlation between ANC and then facility for delivery. And so we can see that there's a positive correlation between the two, which simply tells us that as many people go for ANC services, the same number of people are also expected to deliver in health facilities, which is a good news for all of us, that if you have many people in your district going for ANC services, then many of them are also delivering in facilities that are manned by health experts. Now, what do we take home? We have some few points that we have to take home and discuss. One, we have observed that antenatal visits is highest in districts in the Upper East and Upper West regions. Deliveries at health facilities is less among women in many districts in eastern parts of Ghana. Utilization of maternal health care services is high in districts with shorter distances to health facilities and vice versa. The last but one take away is utilization of maternal health services is highest in districts in the Upper East region, which we all saw. And then the last one is that there is a positive correlation between those who receive a minimum of 4 or plus ANC visits and facility delivery. Thank you very much.
Thank you so much, Dr. Kobna Abaka Ansah. Let's keep the applause coming before Dr. Abaka takes his seat. That was an insightful presentation giving us a disaggregation of what has been happening around or across the districts in the country. Let's take a presentation on adolescent risky sexual behavior. To help us with this is the Director Methods and Standards Directorate at the GSS, Peter Techi Pepera.
Thank you very much, and good morning, everyone. Yeah, I'm going to do the last presentation, and as we've heard, it's on adolescent risky sexual behavior in Ghana. And this is the outline of my presentation. I have a little background, study design, objectives, key concepts, risk factors, the findings, and highlights of a few consequences and key takeaway. Now, so far as this work is concerned, the adolescents that we are looking at are those in the age bracket 10 to 19. And globally, currently the population of the adolescents is 16%. And in Ghana, from 2021 Population and Housing Census, it is 22%. From the DHS, 1 in 10 adolescent girls have had sexual intercourse before age 15. There has been only 2% decline in the proportion of adolescent girls who initiated sexual intercourse before age 15 between 1993 and 2022. And you could see that the figures are from 12% to 10.2%, in spite of numerous educational programs discouraging them from that. From the same 2022 Demographic and Health Survey, we got to know that 15.2% of teenage girls got pregnant. Out of that, 4 had a pregnancy loss, either through miscarriage or abortion. But the other side of it is whether the abortion was the approved one or not, looking at the age bracket they find themselves in. Well, nearly 11% became mothers. In other words, they gave birth and had a child. There has been 3-fold increase in the prevalence of sexually transmitted infections among female adolescents 15 to 19 between 2003 and 2022. Thus, it has increased from 2.2 to 7.1. On the side of the males, we've had 5-fold increase. In 2003, it was 2.2, and in 2022, we had 12.5. From the Ghana AIDS Commission, adolescents 10 to 19 years constituted 6% of the total HIV population in Ghana. And in 2022, out of the cases, the new cases that were recorded, 10.8% also falls in that age bracket. We've heard that the study relied on what? Small area estimates to help us get estimate for all the districts, that's 261 districts in Ghana, by utilizing the 2022 population and housing census, 2021 population and housing census, and the 2022 Demographic and Health Survey. And this exercise is aiming at shedding light on the factors that influence adolescent risk sexual behavior, the prevalence, the consequences, identify high-risk areas, the districts that the prevalence is high or are high, and to trigger the importance of addressing adolescent reproductive health needs comprehensively. In the earlier presentation, we saw huge percentages, and I think we were happy hearing that some figures were nearly 100%. In my case, if you see high figures, get sad. We try to look at the results in these 2 areas: underage activity, that's underage sexual activity, and multiple sexual partners. If we say underage sexual activity, we are referring to a female or a male adolescent who gets themselves involved in sexual intercourse before age 16, which is the approved age for having legal sex. And when it comes to multiple sexual partners, the DHS try to figure out how many people, either a girl or a boy in the age bracket 15 to 19, slept with 12 months or had sexual intercourse with 12 months before the data collection. Be it one person throughout the 12 months, or different people, one, later you jump to another boyfriend or girlfriend, or concurrently having 2 or 3 boyfriends or girlfriends. Now, we've heard about what usually drive them to get into it. Some of us, when we were young, try to be a bit curious. In whatever we hear, we want to try. Some also get into it through what? Pressure from either friends, peer, or even family members. There is this young guy here, or there is this man who is rich. Get closer so that we get some money to support the family. Some are also coerced into it, giving them money, buying gifts for them, and after that, we force them through aggression or whatever means to have sex with. Of course, we've got to know that from the analysis we did, the cases differ from urban and rural, and there's a high possibility of seeing variation in girls who have had higher education or whose household's economic status is relatively better, and so on and so forth. So these are all some factors we related the findings to. Not that, in fact, I wouldn't present results cutting across all these, but at least it gives us an idea that these are factors that influence underage or multiple sexual partners, underage sexual activity or multiple sexual partners. Now into the results or the findings. These 2 maps, as you are seated, the one on your left is about the girls, the underage, meaning they had sex before age 16. But of course, it's we looked at the population 16 to 19. And we engaged them to find out when they had sex, the first sex, and so on and so forth. And you could see that it is concentrated at the middle. The lighter color tells you that that area, even though it's ongoing, the prevalence or the number of girls or the percentage is not as high as the deeper one. So you could see the situation is concentrated around Obuasi area at Kumasi in Ashanti region. And if you look at the western part also, the pointer is not helping me. Okay, this side. Okay. And what baffles my mind, let's look at the one on the right. The concentration is in Eastern region. That's most districts in Eastern region are dense. In other words, the prevalence is high. But this is for the boys. And if you go to the left one, Central region, even though we have higher concentration in the bracket 20 to 30 and few 30 to 40, that of the guys in the same age bracket is dense. The question is it that the boys are doing it with few girls? In other words, putting pressure on those girls, more males, small number of females having sexual activity all the time, and the critical thing is the underage is the issue. Now, we try to look at the top 10 and bottom 10 districts across the 261 districts in the country. And you could see that for the females, the first 10 cases are from Ashanti. The list, which is Bungbulugu, Nakpanduri, 10.9, is telling us that the females 16 to 19, 10.9 were involved in what? Underage sexual activity. But that figure is about 4 times that of what is happening in a From in Ashanti region. And you can relate it to all the top 10s. The question is, what measures are we putting in place to discourage this? Because having sex at the early stages has its own health implications. If the girl is not full, the reproductive system of that young lady is not fully developed, we know the consequences. There is the right side is for the males. And the first 10 is also from Eastern region. Our educators. I know Ghana Health Service educates us on healthy reproductive health lifestyle. I know National Population Council engaged some youth on peer education. I know the CSOs, the NGOs, taking a lot of money to intervene. Please, these statistics are giving us pointers where we should go. And you can review your approaches to ensure that at least we help reduce the high percentages of young guys, young ladies getting involved in sexual activities at that tender age. Districts in each region with highest and lowest prevalence of underage sexual activities. You could see wide variabilities in the female figures. The first region, which is Western, the highest is 34.9 within the region that's Efiakwesiminti Municipal. Sorry, Wasa East against Efiakwesiminti, that's 22.5. And that wide variation of 12.4. Is it that some measures have been put in place to discourage that in Efiakwesiminti, and those in Wasa East are not doing much? So the figures are giving us information within the regions, looking at the variations. But if you relate the variation also from the lowest, that's Ahafo, and what? Ahafo and Western, you could see that it's about 3 times that. Let's look at that of the males. Between the last region, that's northeast, the lowest, that's Mamprugu Mungduri, having a variation of 0.7, and then Upper Menyakrobo, the highest 5.4. You could see that there is about 8 times. The Upper Menyakrobo is 8 times that of the lowest. And all these are calling for what? Proper and appropriate interventions. It's scary, isn't it? Now let's look at the situation of multiple sexual partners. That one we looked at 15 to 19. The concentration, deep red, is in the Western region and Western North. Of course, we have some around Ashanti, Sekendi, Itakradi area. And if you look at the right side, that's Uti region, below Dambai, certain activities are also going on. but it's relatively lighter. Let's relate it to that of the males. For the males, the deeper one is also almost at the same area of as that of the females. That's the western region, but it varies slightly when you get to the western north. But the question is, if you look at the entire Uti region, that where we have Dambai, it's thick. And it goes back to the question I asked earlier regarding the underage sexual activity. Even though it's ongoing on the part of the females, here it is thicker. It means a lot of guys in the age bracket 15 to 19 are indulging in what? Multiple sexual encounters. What is the implication to us as a country? The top 10, as you could all see, we have the Bono, on the part of the females, we have Bono Western North running through first 10. The last 10 is also concentrated in the northern region. And you could see that of the northern region, that of the Bono, the first, is about 4 times that of the northern, that's Karaga. What are they doing in the northern part of the country that those of us in the predominant zone are not doing? Is it about cultural factors? Even though we've heard that it's more of behaviour. Are there some measures that we are to put in place that we are not doing? Let's think through. And if you come to the male side, the situation is worse in Uti region. We need to move in there with all the strategies to discourage that. I'm a young guy. It could be that I'm still in school. I've not settled, but I have multiple sexual partners. Have we thought of the health implications? Can this person develop very well academically and economic side? Munisi can open my baby. The highest and the lowest prevalence, and you could see the same pattern among the males and the females, as the variability is wide among the females generally as compared to that of the males. Now, I mentioned some of the consequences, but to reiterate, we are all aware that getting into such act, mostly you go and hide. Either you are forced a bit, you don't want others to see, and therefore you may not even prepare well. So it comes with what? Unplanned and unwanted pregnancies, unsafe abortion, because you don't want your mother or any elderly person in your house to get to know. They take so many things to abort it. It comes with so many sexually transmitted what? Infections. You can talk about gonorrhea, syphilis, HIV, and other things. Human papilloma virus usually affects the females. And frequent infections could lead to what? Cervical cancer. And if you go through all these as a young lady and you don't get support, you may end up going through depressions, frustrations, and what have you. Substance use cannot be ignored. It's possible you may find yourself among some young guys, gangs, your own friends, and maybe be subjected yourself to what? The use of drugs to have your peace of mind. And normally when they are doing that, they don't think about the long-run consequences. The key takeaway, we've got to know that underage sexual activity and multiple sexual partners are becoming a threat in society with high prevalence among females than males. Underage sexual activity among female adolescents in a Krofrom, in Ashanti region, is 4 times higher than the Bunklubu Nakwandori in the Northeast District, and 8 times higher in Upper Menyakrobo in Eastern region among male adolescents than their counterparts, that's the lowest in Nandom and one municipal. Female adolescents with multiple sexual partners in Doma East in Bono region is 4 times higher than that of the Karaga in Northern region. And on the part of the males, the highest is in Guan, in the Oti region, as against the lowest, Krowo. And we've got to know that that of Guan is about 5 times that of Krowo Municipal in Greater Accra. Ladies and gentlemen, attention must be focused on young ladies who reside in districts in Ashanti, Western region, and Bono East region regarding experiencing underage sexual activity. Thank you very much.
Thank you so much. Please, let's keep the applause coming. Dr. Pipra has done a great work, just as that of Dr. Abaka Ansah. Talking about adolescents, we'll zoom in straight in and call on the UNFPA representative who happens to be the program specialist, adolescent and youth development, Ajwa Yenyi. A round of applause for her. She will give us a brief remark from UNFPA.
Maybe it's still in the morning. Feels like the afternoon after hearing all that we've heard today. But good morning, everyone, and thank you so much. I'm really happy to be here. And honestly, I'm sitting in my seat and just shaking my head left and right and seeing that there's so much that still needs to be done. At UNFPA, we want to ensure that every pregnancy is wanted. So you can see the linkages. Every childbirth is safe and every young person's potential is fulfilled. But if these are happening, how do we fulfill the potentials of young people? So today we recommend our partners, the Ghana Statistical Service under the able leadership of Prof, for its commitment in bridging the data gap at the subnational level, as we've seen. This is very critical, honestly. It really, really informs policy direction and the kind of interventions. We should stop having this one all-in-all intervention in the Ashanti region, but begin to look at the details and what needs to be done for optimal results. The focus here from what we have seen today has been very, very significant. Of course, we need to continue to ensure equitable access to maternal healthcare services, reducing maternal mortality, and ensuring universal health coverage. And of course, issues around our adolescents. I think because we are adolescents, we are still, in that stage where they are young people, but we have the experience. So we still need them to keep quiet so that they listen to us. But if we do not move and move quickly, there's going to be a lot of issues. UNFPA is proud to support efforts such as this, which prioritize evidence-based planning and localized interventions. And these reports and the scorecards are going to go a very long way to ensure that we as the UN begin to look like how we invest in interventions in the country. I just want to just commend all the partners once again and just mention that UNFPA is really committed, and we will continue to work with the Ghana Statistical Service, our UN family, civil society, many of whose faces I can see here. And we want to ensure that we can achieve a shared vision, which is a healthier Ghana and a Ghana we want. In order to have a Ghana we want, we need more of these. While we're looking at the statistics, just because of the very last slides. So we have all these young men in Oti region who have multiple partners. As we begin to explore this data, are they using condoms consistently? Are they? Or for instance, what is the teenage pregnancy in these areas? Is it sugar mummies who are making these young men get into sex early? So there's so much we can do with such data, and we are very happy that we have such an eye-opener that helps us to know how to move forward in our intervention. So thank you so much. I really look forward to the questions and the discussions that will help us also set the pace for how we can continue to support such data collation and how it will help in our interventions. So thank you so much.
Thank you so much, Madam Ajua. Indeed, as you did indicate, myself, I was shaking my head and wondering, what are we going to do? What ought to be done? What is the time limit? What time do we have to ensure that these do not escalate? Because it does not only have health implications, but it comes with social implications as well. At this juncture, we will take a 5-minute snack break. Snack has been served right behind you. In case you would want to use the restroom, it's right behind you. The exit is there. So we are taking a 5-minute break, ladies and gentlemen. So you can go to the back and grab something. It's 11:33 now, so we will be back by 11:38. So snack is served. Right after snack, we will be taking remarks on what the policy implications of the two wonderful presentations we have received would be. And we would have Dr. Athanasius Aiti Lebi and Professor Patrick Esumin helping us with the details of what this means to us as a people. So please, snack is served. Enjoy. Break over, please. Please kindly take your seat so we can proceed with the rest of the program. Okay, so we are beginning with the second part of today's program, but before we go ahead with the policy implications of the findings as has been presented to us so far, we want to make some few acknowledgements of various dignitaries and institutions that are duly represented here. First on the list, Rebecca Kumi with UNICEF. Thank you so much. We also have Med Ugoro with the UNFPA. Muntaro. Okay, so thanks for the correction. So Mohammed Muntaro with the UNFPA. Thank you so much for coming. Next on the list we have, I don't know whether it's a lady or a male, Sophanias Asrat. Is he a lady or a female? A male? Sophanias Asrat with the WHO. Okay, I think he was around a few minutes ago. We also have representatives from the National Population Council. A wave will do. Thank you so much for coming. Ghana AIDS Commission. Ghana AIDS Commission. Thank you so much. PPAG. PPAG, thank you so much for coming. Institute of Statistical, Social and Economic Research, ISA. Rep from ISA. I think I saw one rep from ISA. Okay, he may have stepped out. Thank you so much. Oxfam rep. Thank you so much for coming. AGI, Association of Ghana Industries. AGI rep. Thank you so much. Child Rights International. I can see Mr. Bright appear here. Thank you so much. Comfort rep. Okay, thank you so much for coming. National Youth Authority. Thank you so much for coming. Nursing and Midwifery Council, or Nursing and Midwifery, thank you so much for coming. And Alliance for African Women rep, thank you so much for coming. So we will be acknowledging dignitaries as and when they join us for the second session. At this juncture, we have been given two very detailed, I must say, very detailed presentation on maternal healthcare services and their utilization, as well as adolescent risky sexual behaviors. We have seen what is happening at the district level. Indeed, that is a cause for alarm. We all ought to be alarmed and find very lasting solutions to some of these problems that are so prevalent at the district level of our dear country, Ghana. One Ghana we don't have any Ghana aside from the one we have, so we have to guard it jealously. At this juncture, ladies and gentlemen, talking about the policy implications of the findings, help me welcome a gynecologist with the Ghana Health Service, Dr. Athanasius Ayete Levy. A round of applause, please. The rehearsals has helped. Yes, thank you.
Thank you very, very much. Let me start by thanking the Ghana Health Service for this wonderful platform to make an input into this wonderful presentation that we've had today. I would also thank the UNICEF for their immeasurable support for this program to go on. And I would hereby ask everybody else to support us in this work, because I was not the only one shaking my head, if I'm not mistaken. And I work in the unit, so it is something I am supposed to know. But still, it is an interesting fact to find that some of the things I thought I knew very well were not as well as I thought I knew them. So I think it's an important exercise that we are doing. We all know the Sustainable Development Goal 3 and what it stands for in ensuring health. And as an obstetrician, I am quite passionate about any issues to do with maternal care, and so therefore maternal service utilization. And so I was very happy that this topic came up. I think I was expecting quite a different perspective on this work. And so let me just go on to say that we all assume that once we are attending health services, then the healthcare personnel has an opportunity to impact upon the care, and so therefore automatically improve the care. So we say that if you are going to antenatal care and then you are having a facility delivery, then you'd have an optimal maternal outcome. But clearly sometimes that is not the case, as we can see in these presentations. And I think one of the biggest things we are seeing that we are always happy with the regional numbers, but they are far, far, far away from what the district level says, and that is the important message we are passing on this morning. I am not here to explain why District A has performed better than District B. Neither am I here to explain why Western Region is doing some interesting things in terms of sexual health, but just to draw on the importance of the work they have done. So I like the correlation between skilled antenatal care attendance, the 4+ antenatal care visits, and its translation into facility delivery, and that was important. And I think they focused on a 4+ visits because that was the minimum required number of visits that we have seen that impact upon outcomes. So if you do 1 or 2 visits, the impact on the outcome is not as high as if you do 4 visits. So we were more interested in looking at the 4+ visits and seeing its impact on health outcomes. And so I am happy we looked at that. I think comparing between the DHS of 2014 and now, there has been some improvement. We are currently at 22 difference. We currently have a higher skilled attendance and a higher visit in terms of the 4+ visits compared to 2014 DHS. And that is a good number. If I look at facility delivery, there's also a difference because I think the DHS 2014 reported a 73% facility delivery compared to a current 86% that we have. So nationally, we are doing well in terms of improvement upon the numbers, but they are still far away because we expected us to get to 100. We have a lot of initiatives that we have put in there to try and get some of these things done. I mean, we talked about the policies that we have, and one of the biggest policies we have was free maternal health care. We thought if we took away the costs of the thing, the women would not have any reason to complain why they cannot go to the hospital and receive care. But clearly, we realize that there are a lot of other things involved that is bringing up this picture. And I'm happy to point that they brought out one parameter that at least tried to show some light on what is happening. And that parameter they brought up was the distance to facility. So in as much as we have taken away the cost, there's a lot of things that impact upon the reason why women will visit the facility or not. And this work is telling us that we need to look at each of those variables well enough to try and help us understand why some regions are doing very well compared to why some regions are doing poorly. And whatever we do, somebody will be last. So I don't want to sit here and say that because this region is last, they have done what not. That's not the important on the message. If I tally numbers from 1 to 10, somebody will be 1, somebody will be 10. But I want to find out those of us who are the 1, what are we doing to stay at the 1? And those of us who are the 10, how can we get to the 1? That is the importance of this message. So I don't want us to skew our discussions to why we have this problem in this district and that region. That's not why we are here. But let us look critically at some of the issues that were raised. And I made a few pointers during the issues that were talked about. So for example, an interesting fact, if we look at the districts in the Upper East region, they perform very well with the 4+ ANC visits, all right? And I'm looking at one particular region, for example, one municipal region, top 4+ ANC visits. But when we look at the top 10 facility delivery, one municipal didn't feature in the top 10. They were top for 4+ ANC visits, but they didn't feature in the top 10, which means that in as much as the region is doing very well, when we talk about the district disparities within the services themselves, that's a problem. And that is why I'm happy with this work, because it's pointing us to us clearly where we need to put the focus. Not just to say that utilization is good in Upper East, so we are fine, but to say even within Upper East and within the service that we offer, let's look at antenatal, let's look at postnatal, let's look at facility delivery. Are we doing equally well for all those measures? And what lessons are we picking from one municipal's topmost position at 4+ ANC visits and why they didn't make it to the top 10 for facility delivery? It's important to look at it. So these are some of the key things that I think the small area estimation helps us to be able to bring out. And I'm happy, like I said, that we did it. There are a lot of indications why we have these problems, I've said. Some of us, we say it's education of the household head, education of the person themselves attending the clinic. We looked at poverty index. We looked like female involvement in decision making. So can I get up and go to the facility without my partner's involvement? All these things play a key role in deciding what are the reasons why we are getting the numbers we are getting. But like I said, for me, the important lesson is what can we draw for those who have done well to help those of us who find ourselves in the 10th position to get to the first position. So that is the importance of the small area estimation, and I'm very happy we are looking at that. If I look at previous DHS and current DHS, and now that we are doing small area estimation, we realize that what some people used to do, they are not doing as well anymore. So like I said, we are doing something. Our numbers have gone up, maybe small in some areas, but they have gone up. But you see, we tend to focus all our efforts, I think, on the performing areas and not push as much at those who are performing well. So we have this warp effect that we get. Those who used to do very well don't stay at very well, they drop. And so I'm happy that this small area estimation has come to show us where the problems lie so we can have some consistency. But beyond that, I think from all the presentation we did, if we look at the disparities, you realize that always the between region disparities was much, much higher as a contributor than within group disparities. So I realize that the regions in Ghana are very, very different in terms of how we achieve our indices. And I don't understand why we are, because it's one country. We are one people. We should be having what we call the universal holistic healthcare. So if it's universal, everybody must get it. And then we'll enter issues of equity and equality and have a lot of issues. Bottom line, if I live in Accra I should be getting the same as if I live in Tamale or if I live in the Eastern region, but it's not there. So realize that at least the within group is a little better. I said that if I find myself within the Eastern region, most places I go within the Eastern region should have comparable outcomes in sales or service. But if I move to a different region, then things change. So yes, the small area estimation is telling us what is happening at district level, but it's also bringing out the bigger picture as well as what we are missing from the regions. So we need to learn these lessons, and that is why we are here. So like I said, I'm welcoming everybody else to come on board to add on to the funding for this work to be done so we can look at more variables, because it's a lot of work to try and understand why we are getting what we are getting. If I will move to the risky sexual behavior, I have shelved my zone and now entering my future. And that was my adolescents. They come and make me who I am, obstetrician. And I'm sad that I have to start my fight so early, because at this point, our shift is going towards HPV and cervical cancer. And I'm happy that the work was done for both male and female, because hopefully the men are having sex with the women and not the other things that we don't want to talk about. So when we look at those numbers, we realize that some regions' worst performance is still way better than some regions' best performance in terms of the early initiation of sexual activity. And he mentioned them. Sometimes they are 4 times, sometimes they are 8 times. So why is it that in my region, the district that performs best, the district that performs worst is still way better than somebody's best region? So that goes back to a point about the interregional disparity I talked about that is contributing to the bigger problem. Because I was very, very, very much surprised about that finding when we got there. The other thing I also noticed was the shift in the initiation of sexual behavior among the females and the risky sexual behavior. Previous DHS showed us the numbers in the lake regions because we thought the women had to be fertile, had to give birth to more children, the children would become workers on the fishing boats and things, and it looks like we have done a lot of interventions there, and we have shifted the story to a different region. So this exercise has told us, did we win in one side and did we make it worse on the other side? Did we shift all our attention to a particular region and ignore other areas? And so for resource allocation, for resource utilization, and for us to achieve equity, this exercise becomes very important so we know where to target our interventions. I was surprised that the males are not starting it as early as the females, because I thought when we do data collection and we ask a man, when did you start, we tend to boost our numbers a little bit and give you bigger numbers. So the information we are getting, is it the real one, or are we even worse off in terms of the disparity? Are the women as worse off than the male? Because honestly, when we talked about risky behavior, it's more in the men. So how come when it comes to risky sexual behavior, it's more in the females? You see, so there's a lot of things that we are not understanding that this small area estimation is bringing out that we need to look at very critically. Is it that we are having more cohesion, more sexual violence amongst the female group that is allowing them to engage in this activity? Because that's how I see it. If I looked at the northern regions, I could say religious, sociocultural has helped, so they're not engaging in the initiation or even in the multiple sexual partnership areas. But if you remove that, then why are the other females joining? Because we thought men are more risky. So why do we see a different thing on the data? So my submission mainly is on these areas. I just wanted to reiterate the importance of the work that has been done to show us the problems that we have, to let us understand that even within the districts, there are disparities. There are huge disparities within the regions, and that our effort should not completely shift focus on the interventions. I think the problem here is a partnership. The different programs are not speaking to each other. So when there's a problem, you identify, we all jump there, and we try as much as well solve that problem in that area and forget the other areas. I think that is what I am seeing from this picture. And so thank you very much for giving me the ear for the little I have to say on this matter.
Please keep the applause coming. Thank you so much, Dr. Ayeti Levy. Indeed, an all-hands-on-deck approach is needed and is so important. At this juncture, I would indulge members of the high table to go back and take their seats at the high table. So members of the high table, kindly take your seats. But Professor Asumin, who is an associate professor at the University of Ghana Business School, will take the floor to give us his remarks on the policy implications of the findings received so far. A round of applause for Professor Asumin. Well, please, members of the high table can kindly take their seats.
Good afternoon, and thank you to the Ghana Statistical Service for inviting me to share remarks on this important report. So, yeah, my co-discussant has said everything that I wanted to say, so I guess I can just say, you know, all has been said. But, so I think, first, I want to thank the Ghana Statistical Service for this piece of work. Because, you know, disaggregating things makes us learn more than simply focusing on regional and national averages. And I think it's something that Professor Nim has always been saying. Whenever he presents other reports and he asks, he always say, well, we need to get to the granular details and learn a little bit more. That way we can make more informative policy. And I think we really have to appreciate the Statistical Service and encourage them to keep doing more of these. So I think maybe I'll touch on two main things. I think one of the things that we've learned following from that is that we can't have a one-size-fits-all when it comes to any policy, not even health policy. Because when you look at the two main reports, they are all on health. But on one aspect, you see the regions that are doing well are completely different from the other report, the regions that are not doing well. So that already begins to tell us that, you know, even if you have a health policy, what may work to address a specific problem in one of the regions may not necessarily work in the other region. So I think it's very important that we re-emphasize this. Get to know what is happening within the regions and within the district. So it's the first main point that I want to re-emphasize. The second main thing that I want to say has to do with something we learn about the inequalities and the distribution. And was that if you look at the inequalities in the indicators, especially the maternal and the maternal health care services, you saw that 75% is between regions and just about a quarter is within the regions. That means that there are more differences between the regions than within the regions. Now, that tells me that if you are trying to bridge these inequalities, we should focus on ensuring more equitable distribution of resources among the regions. It was interesting to hear yesterday, I was listening to radio, and we know what is catching our attention these days is that some people have been nominated as ministers, and they are being vetted. And I heard a discussion breaking down how they are ensuring regional equity in terms of the distribution of who is getting posts. But I think it's even more relevant because of how the decentralization we are implementing and how the Ghana Health Service is also working, that we ensure that the resources are fairly evenly distributed across the regions. If you do that, it means we are 3/4 of the way in bridging the inequality gaps, and I think that's very important. So thankfully, reps of the Ghana Health Service are here. So I don't know whether this means that within the, once you allocate resources and get to the region, it appears that at the regional level, the regional directors are better at ensuring that there is equitable distribution than at the national level. So perhaps that is where the problem is. And that's why we need to pay a lot of attention ensuring that every region is getting its fair share, because it appears that once it gets to the region, at least it's being fairly equally distributed. The other thing I wanted to point out, outside of my main points, is, so you look at the regions performing very well in maternal health, especially A and C, Upper East and Upper West. Now, if you are thinking about, if this was based on income or poverty distribution, the income-based poverty measure, you always think that the poorest, one of the poorest regions has always been Upper West, right? But we look at the health indicator and we begin to see, they are actually doing well. So there's a lot to learn. One is that we can't generalize from the economic to the other sectors of our lives. We can, just because some region is economically among the poorest, it doesn't mean that in terms of other resources they are poorest. And indeed, in particular for Upper East, I think there's a lot for the other regions to learn. What is it that they are doing differently that consistently across the other indicators, they seem to be doing very well. Now, on the reproductive, the adolescent health and the risky behaviors, I think mostly the ops have already explained the main thing, so I wouldn't want to say too much on that. Except to say, I found it curious that the regions that have the highest rate of sexual initiation, or let's say it's illegal sexual initiation, really, because having sexual encounter before the age, somebody is committing an illegality. That's what it is. There's no beating about the bush. Because if you had a sexual encounter with anybody below the age, somebody is committing an illegality. The question is whether they are having these encounters with other underage boys, or who exactly are they having these encounters with? And how are they being addressed? Who are they? Clearly, when you look, you realize that for the males, it was Eastern region. And for the females, it was Ashanti region. Even though they are contiguous, I guess we can say that probably the males are having it with some other females, and the females are having it with some other males. More likely to be people who are senior. I think child rights is here, and other people who are more knowledgeable on the specific case are here, so they will tell us. The question is, the trend is that it is increasing, it's getting worse. We are seeing 3-fold for the females and 5-fold for the males. Some people are committing illegalities and getting away with it. So I think, like it was suggested, a holistic approach, perhaps, are these cases being reported, and are they being swept under the carpet within the communities? Or is it that, do these young girls really want to be violated? Because that's what is happening. If you have a sexual encounter with somebody underage, you are violating the person. So is it that, these young girls are consenting? Obviously, they are below the age of consent. So who is reporting them, and what is being done? Is it that families are hiding them under the carpet, or is being dealt with? Because something has to happen. For me, when I look at it, I just see it as plain illegality. Some consequences have to happen. Yes, it's good that we give all the health education and we encourage them. We've been doing that. And things are still rising. So maybe it's time for us to, alongside doing that, trying to consider the other policies, making sure that people who are committing those crimes in the communities, they are getting reported and swift action are being taken. So I will end my comments here. Thank you so much for attention.
Thank you so much, Professor Smain. So at this juncture, it is time for questions and answers. In case you have a statement or question, you can raise your hand and the microphone would be brought to you. So question time. So we'll be taking, I think, we'll be taking 5 questions. Okay, 3 questions for the first round. Then we'll come back for further questions. And you can kindly note who in particular you want to address your question. Please wash your hand up. Thank you.
questions or comments?
Yes. So questions or comments?
Okay. Thank you very much. My is a comment, maybe to end with a question. This has been very insightful presentation, evidence-based, that can give us a direction. Before this, we've been relying on the DHS. We've been relying on the DHS for program intervention planning and national level policy planning. But however, this is more detailed. My comment is on the policy level. You will notice that the policy or the age at having sex is 16. However, the age of marriage is 18. That 2-year gap, we have been struggling how to make a policy recommendation for the collapse of these 2 years. Late last year, there was a parliamentary delegation that visited Ghana, Parliamentary Forum on Population and Development in Africa. When they came, we had interactions, and this issue came up. And they asked us, so what is Ghana doing about these 2 age? We said we have spoken with the parliamentarians, but they keep saying they don't have the evidence. It's difficult for them to get evidence to push on the floor of parliament a policy that will bridge this gap. I'm sure we now have the evidence. We now have the evidence, and we don't longer need to wait. We have an opportunity to meet this new government. And GSS, you can repackage this because policymakers don't have time like we have to sit down for 2 hours. You can repackage key issues, meet government, and meet parliament. Meet parliament with this evidence. I'm sure they will have enough now to push for the collapse of these 2, because the age is giving us a lot of problems. And that, 1 minute. Oh, okay. They are reminding me. So the age gap is giving us a lot of problems. You can see the underage sex, and I'm happy you did 15 to 19. You can compare the 2 to justify the reason for moving the age at the sexual intercourse to 18 instead of 16. Thank you.
Thank you so much. So I think there was one hand right behind him. Yeah. So that was a statement. So if yours is a question.
Thank you very much for this opportunity. My question is actually twofold. I want to focus on the adolescent risky sexual behavior. Now, I want to ask, the first question is, what was being done in the past? When I say in the past, I mean before today. What was being done to address the situation? And what is going to be done? Because I heard a lot of the speakers saying a lot needs to be done. So what is going to be done to address it? Thank you.
Okay. Okay, so we can pick 2 more questions, because the first one was a statement. The second one was a question on what was being done and what was being done and what is expected to be done. Okay. So do we have any more questions? Okay, so there is a hand. Mr. Paul, there is a hand. Yes, please.
Yeah, thank you. So my question goes to the presenter on this sexual activities. We could see the disparity in the eastern region and then the Ashanti region for the boys and girls. So my question is to the presenter, in your opinion, do you think social media has the influence on that activity? I don't know, it plays a major role for us to have that disparity in the issues on online sexual activities and those kind of things. Thank you.
All right. So I think we have 2 questions. So we'll take a final question. Do we have any hand? Okay, so we'll take from Mr. Bright up here. Then that will be the first batch of questions.
Thank you. My question will be on the maternal health services. In the presentation, I realized that children below 15, attend maternal health services. And as Prof said, someone is committing illegality. So children are not supposed to even get to a level where they will get pregnant to access these maternal services. So I wanted to find out whether, first, whether when they go to the maternal, to access the maternal services, there are other services that you realize they get when it comes to maybe criminal activities or reasons why who impregnated them to even be there for the first place. And secondly, when they are accessing the services, what are the kind of services that they are rendered to? Because for me, they are below age for them to, though it's good for us to see that they are accessing the maternal health care services. But from my point of view, I don't think that they should even be there in the first place. So I would just want to understand the dynamics.
All right. Thank you so much. So members of the high table, there is a microphone. You can kindly do us the honors. So our first question has to do with what has been the situation in the past and what is expected to be done.
Thank you very much. The first question, what was the situation?
Yes, so what has been pertaining and what are we expecting following the findings?
I would say that this is something that has been in existence in the past. But this is the first time we've gone down to the district level to, I would say, unveil it. We are all aware in our communities that some young girls indulge themselves in what? Sexual activity. The question is, do they decide to get into it, or it is the men who entice them to get into it? Has that approach changed? We are aware, in fact, I linked the districts that underage sexual activity is prevalent to the districts we know having galamsey activities. And you could see that if you map them, a lot of them are in the galamsey areas. Is it influencing that? Because we all know that mostly galamsey is or attracts men or males more than females. So you get to a locality, we have about 1,000 males, and if you count the number of females, they are few. And more especially these young ones, is disproportionate. And when men make little money and they want to enjoy themselves, what comes to mind? Alcohol and women. So if you meet a woman who is married and you can't have access, you target the young ones. Those who are vulnerable, you want to entice her with just two cedis, 10 cedis, buy yogurt for her, buy ice cream for her. Sometimes you take her to, they are taken to their rooms to watch videos, TVs. Some move to the extent of buying phones for them, and all these things happen. Okay? So this is more of social issues. And I think my brother here asked the question about, is social media influencing that? To a large extent, I would say even yes. Or I would say yes. Those days when there wasn't phone in the system, if you want to call your girlfriend, what do? I learned those days some of us will go and stand behind the house and throw a stone on the roofing sheet for the girl to know that he's around. Today, we've been testing what? Messages to them. We share some porn videos with them on WhatsApp. What are you communicating to that person? Indirectly bringing her mind on it, enticing her to get involved in all these. So it's a huge problem. And the question is, moving forward, what do we do? How do we bring it down? How do we intervene? I think it calls for more education. Not just in schools, but in our communities. the NGOs, maybe you have to review your approaches. Are we to gather them somewhere, educate them, maybe with movies and the consequences? Are we to beat the drum all the time to their hearing that underage, if your reproductive system is not well developed, you are exposing yourself to so many what? Health hazards. And as the question was asked, how many of them even think of negotiating for the use of condom? In DHS, we have that question, that did you negotiate for condom use? As part of 2022 Demographic and Health Survey, we also did qualitative part. The qualitative aspects that try to figure out how girls get into their first sex. And it was done in Ashanti region and northern region. And you could see that most of them are entitled with material things. Few got into it out of curiosity, based on what their friends have been told. And then, I'm aging, let me go and try it. But these are all challenges associated with this that I don't think I can say one problem or one cause, and therefore, if you tackle this, you are good to go. It's due to multiple factors. So it calls for you and I to sit down to strategize. Are we educating them in our churches? Are we educating them in the mosque? Because in Ghana we know that Muslims and Ghanaians, and Christians constitute more than 95% of the population. So can we plan and target the education towards certain environment? It's so many things. It's called for so many deliberations. So I will leave it here, and if my colleagues here would like to add on.
Okay,
yes.
So
I know it's in your domain.
Good afternoon, and standing on existing protocols. And so for the first one, talking about the age, the 16 and the 18. And as you may know, even 18 years, cast your mind back to your own homes. Those who are 18 in your homes, how developed are they? So if you were to ask me, as an individual here, I'm going to ask that we push even the age up. Again, before, men are allowed to marry in the law at 21. Females is 18. It was some time back the parliamentarians put the situation that the consent for sex and brought the age to 16. They brought it, so they should bring it back to where it was. And so my concern is, when you look at the regions in which we're talking about, just having a discussion with doctor, where we're seeing that where girls were initiating sex first, it was not the same in proportion as males initiating sex. So who were the girls sleeping with? Age of sexual debut, where were they having it? So somebody introduced a girl to it, and this might be somebody who is senior to that person. And so it means that either you are coercing them or you are forcing them, or based on what Dr. Pepper talked about. So I think that it is not healthy for us. I don't think that my daughter who is 16 years, I think that that person should be exposed to these things or should get even the risk of becoming pregnant, because when you having sex and becoming pregnant, there's a thin line between them. You don't think that you should have it maybe 1 hour or 30 minutes before you get pregnant. Quickie can make you pregnant. And having it for 20 minutes or 30 minutes can make you pregnant. And so it doesn't mean that when you just have it for just 5 minutes or 3 minutes, you can't become pregnant. And so please, I think that if we are looking at this policy, I know you are coming for UNFPA. So you may also have a voice there. Let's leverage our voices together and then engage. And let's do the right thing, because I think that it's not too good for their health. Our boss also talked about when girls are 15 years and they are pregnant. Provided you are pregnant, even though it is illegal, when you are pregnant and you get a health facility, the most important is that we ensure that we save every life. And the health of the mother as the unborn is important to the health professional. So that's why they have these the friendly centers, so that when these young ones go in there, it is not there that you are going to penalize them. You have to encourage them at that time to be able to go through the system, but there's education for them, so that when they have delivered, we ensure that they roll back to school and they continue with that. So it's not like because you are 50 years, you are pregnant, when you come, we'll not open the doors to you. The doors must be, provided you are pregnant, the doors must be open and help that this pregnant young person has, get all the support and the care to ensure that she goes through the process successfully. And again, with the medics, if they check and it is too risky, they know what to do, because the law allows those ones in their own domain. But when they think that the person can go through, they will assist the person to go through. So it is not there that you penalize the person. It is because when you go through that process, it's a stigma. There's you are disappointed, you are in a state of despair. So if you come there to rebuke at that time, you are just adding injuries to that person, and then the person, if you are not healthy, you will not carry a healthy baby. And the new one that's going to come out will also be carrying things that is not healthy. So at the beginning, say when somebody is pregnant, the most important thing is that when they get to the health facility, they have to ensure and help that person to be able to deliver safely there. And so that's why the nurses are even taught that you don't just go and say, hey, auntie Fosiba, Melko di nipa ba and our benin. That is not what is done there. You must help that person to go through that process in them. Then I'll finish and come to you, sir. And then the other one that we talked about, what were we doing in the past and what are we doing now? When we talk about education and Savannah is not doing well, all the people in my office, they point their hands towards me. Today that Savannah is doing well, you people are not talking about it. And so one of the things that I think, what were we doing in the past? In the past, like he said, these cultural norms that we have, I think that because we know the consequences of unprotected sex, consequences of indulging in this activity can have on the child, I think that we should instill, and the beauty is that whether you are a traditionalist, whether you are a Muslim, or whether you are a Christian, all these religions we practice in Ghana here frown on teen pregnancy. And again, this initiation of sexual debut before marriage. And so if we believe this, and that's all we all practice, then we should instill this in our children, in the community that we are, so that people will be conscious that we do not, or society does not accept that one. Now everything, like anything goes. So please, what we can do now that, please, if you have a brother or you have a sister, please tell the person, aketesia, katahusie, the way we dress, the way you encourage us to dress. If I'm not well dressed and you don't say it at home, and I take it out there and somebody rapes me, will you say the person who is out there is at fault? Both the person who raped me and you, my mother or my father, or whoever bought the attack for me, you are all supposed at fault. And so what are we doing? Now in social media, my young friend, you did mention what are we doing now? Just as you talk about social media, sending new things to people. Somebody tells the person, send me nude pictures. Somebody say, I met my person on the internet, whether young people. And one thing that you've realized that when you are even I have a game I call 2248. When I play the game during the day, no other comes. When it is 5 p.m., it gives you questions on things that you've been doing that day. After 8:30 p.m., it changes the questions. And then now you begin to see that small spots of whether watch this one and see people maybe have naked or click and then watch this episode or whatever. And so even children, the educational gadget they learn with, please let's ensure that we put safety on them. During the day, even those who put kind of adverts for them to see, some of these others don't come. After 7, 8 p.m., even though they might be doing their homework, sometimes this case or this shape of a woman or whatever, it pops up. And children are curious. They want to see. So what are we doing? What we should do is that we should also educate people that, yes, having rights, giving tablets to our children, but put on devices or put on measures that will protect these people. And again, young men and old men here, when you see our young ladies or you see our young ones, you can encourage them, but please don't lure them. In the same way, young women, big women in positions, when you see our young men, encourage them. Don't lure them into your beds. Thank you.
Thank you so much. So that was our Deputy Government Statistician, Dr. Faustina Frimpong Engwa. Thank you so much for those insightful words. Do we have some few questions. Okay, so I think I'll do a last round of questions considering the time spent so far. Okay, so microphone, please. Kindly get the microphone to, yes. So there is a hand here. So we are taking 1, 2, 3. Okay, then so this is our final lap.
Okay, thank you very much. My name is Jefferson Asari. I am coming from Ghana, Registered Nurses and Midwife Association. With adolescent risky sexual behavior, I would say that I wasn't surprised, but I'm only alarmed by the figures, because when you sit at the hospital and you look at the number of WACs coming in and other complaints from young kids that you wouldn't expect, you know that they are doing things that will cause these data to rise. But my first question is, we are talking about Ashanti region, and who is leading these ladies or young girls to sex? Who is leading the young boys in Dambai, Uti region to early sex?
Okay, so you want to know?
Yes,
who is
I want
leading?
to know.
Okay,
because we should be very curious. It is not only about men luring young girls to sex, but something needs to be happening around that area that we need to know. My second question will be the vast difference. Whenever there are interventions, they are all moving to northern region, because we think that economically it is poor. So every intervention is moving there, leaving the southerners thinking because of economic indications, they are okay to cater for themselves. Economic value does not equate health values. So I am asking, what are the NGOs, the SEOs, what are they doing at the southern part? And what is the sustainability plan they have for these their programs? I have been part of adolescent and reproductive health, where we're forming clubs in SHS from UNPA and Pavilion. But with time, the program is not running again. They will leave it to Ghana Health Service, and there will not be any funding. Right. You have taught them a lot. Now you are not giving them feedback again. What are they using that knowledge for? These are some of the things that we need to look at. Okay. How are we sustaining these programs?
Thank you so much. So sustainability of interventions. Please, let's keep our questions very brief. Time is fast spent. I want us to leave here in the next 5 minutes. So please, let's keep our questions very brief and straight to the point. This is the final batch of questions, please.
Okay, thank you for the opportunity. I would want to touch on adolescent risky sexual behavior. My question, okay, it's a question and it's a contribution at the same time. That's fine. So what I want to find out is, do we have services fashioned for just our adolescents? That's what we have to look at. I know in the past we used to have the adolescent clinic, Ghana Health Service, if you could confirm that. I don't know whether the clinics are still running, and if they are not, I would like to know why. And if they are running, we would like to find out what services they are offering, and if there's a way of strengthening the services they offer, because I believe it to go a long way to help reduce the sexual behavior of our adolescents. I also want to know if they are at the district level, because I know most of the time these services are usually at the regional level. So now we know what's happening at the district. Is it possible to move it to the district? Is it also possible to look at the services they offer there? If they could, you know, adolescents are unique individuals at a stage where they need some form of support. Is it possible to reach out to them instead of us waiting for them to come to us? So these are the things I would like to ask.
So we'll take the final question. There was a hand here. Okay, so that will be our final questions. But our directors and policy, those who did the various presentations are here. So Okay.
Thank you for that insightful presentation. Mine is also on the adolescent risky sexual behaviors. I'm Winifred from the Ghana Education Service. I want to find out the data you collected. Did you segregate it for in-school and out of school, or it was just adolescents in general, so that when we are developing intervention, we'll know how to channel it? Thank you.
All right, thank you. So I'll take the final one from Madam Ajua. She wants to make a comment. Okay, so
please, mine isn't a question, it's a contribution. I think that one of the things that we are missing out as well is our sensitization and education, because I believe that apart from the homes or the schools, now adolescents mostly spend their times outside with people actually bringing them up and educating them. So we used to have adverts and educational videos on TVs and on radios. And these things stuck to a lot of us, or a lot of people. There are a lot of things that stuck with people, that they knew that when they get to certain environments that they need to say no to certain things, they would. They wouldn't even have to waste time to think about it twice, because they have this education in mind and at heart. So I feel that sensitization and then contributing to these factors on TV and radios would do more good to us.
Sure.
Thank you.
Thank you so much for that contribution. Very much noted, and I can allude to that because immediately you mentioned Akwadao coin. I remembered. Medeme call library, you know, and it works a lot of magic. So I think we can capitalize on tools such as this to make progress. Okay, so I'll take the final contribution from Madam Ajura from UNFPA.
Okay, thank you so much. I just thought I would chip in a word here that when it comes to the issues of adolescent health, there are a lot of unanswered questions. And I think the studies like this will help us to be able to delve deeper. Because when I look at some of and why is this happening, and it shows that there's so much more that we need to understand about the terrain to be able to target our interventions.
Yeah.
For the UN family, our primary job is to work with government to ensure that we can ensure there are sustainable interventions. So you see that a lot of the work we do is with government and CSO partners, some CSO partners. And the idea is that when you work with government, because government already has a structure, it becomes sustainable. So how are they integrating interventions within existing structures? Because we also resource mobilize. I'm always writing proposals to get money. So when that ends, what happens? But we can't say that because we are resourcing money also, we shouldn't do anything. We need to start doing something. We need to start taking the steps so that we can ensure that some of these things are over. So the idea is really how each intervention or each program has a sustainability plan. It is always part of the program proposal with our partners. So at the end of the day, if we are integrating into maybe Ghana Health Service, because I understand the issue my brother raised with, I think it was Palladium. Yeah, there was a program with Palladium. And it was all in an attempt to understand how can we make sure that young people have services after they've done all the things that they should do or not to do. When they go, how can we ensure that they have services? Or they have somebody to talk to who can say, no, don't do this, yes, do this. But it was supposed to be integrated within health structures. Over the years, some have worked in some areas, some haven't worked. We've tried standalone, we've tried with health facilities. So even at the Ghana Health Service level, there's still a lot of learning. And I think with these kind of studies, which will help us be able to delve right to the district and find out what is happening and what the situation is, we'll be able to have much, much more better results.
Thank you so much, Madam Ajua. So that answers our sustainability question that our brother there asked about. So now members of the high table can deal with who is leading who, both men and women, who is leading who into early sexual activities and all that, and also what services are available for the adolescents at the various districts, municipalities and all that, and also the data gathered, is it in school or out school in terms of the respondents? So members of the high table, you can then do us the final honors on these questions.
Thank you very much. Who is leading who? This question will be thrown back to you. Statistical Service has done this survey, that's demographic and health survey, of which data was collected and analyzed at the regional level. And this small area estimate procedures has enabled us to link it or triangulate it with the census data and shared. It's bringing out interesting results. When it comes to behavior, it's difficult to say that this person is leading this person because it's difficult to trace the genesis of it. And this sexual behavior, being good or bad, can be traced back to about 1,000 years ago. But now the dynamic and the effect, the health implications, is what we want you to think about and together help to reduce it. I wonder if we can eradicate it. Impossible when it comes to sexual behavior. So who is leading who? I'll still leave it open for all of us to think about it. Now, the in-school and out-of-school question. This survey was carried out at the household level. We have a question about education, whether the person is in school, has completed school, has no education, and so on and so forth. That's educational level of the person we spoke to. And on one of my slides, talking about the factors influencing it, if you get to the main DHS report, you'll get to know that, and even the products out of this, you'll get to know that females and even the young guys with no education, or let me say with higher education, are at less or practice this less risky behavior compared to those with no education. So education plays a role. It depends on how you want to carry out your analysis, like the question you've posed. If you want to delve deep into the data set to determine the percentage, I think it can be done in collaboration with GSS, depending on the objective you put out there. I would say that this exercise has created a very good platform for further research and has also created a platform for us to get more work to do. Because if you look at demographic and health survey report, as we've all heard, it's at the regional level. Sometimes we push, when we engage the health people, that we have so many indicators in this report. Can't you do A, B, C, D out of it? But of course, releasing funds from the government side on timely basis to execute certain tasks is a bit challenging. But as it was mentioned, sensitization of the general public. I know most NGOs are good at it. The CSOs, can you pick it up? Unfortunately, you don't hear much, or you don't hear it at all on our radio stations. We devote about 80% or 60% of the airtime on politics, or topics that have persons in politics being linked to. I don't know whether we can rely on some of these findings, develop a strategy, develop a framework, and start rolling them out. This is just the beginning. We are in January. February, March up to December. Can an institution pick it up that every week I'll pick something on education of these young ones to ensure that they run away, let me use that word, from the canker associated with risk associated with sex, or this risky behavior when it comes to sexual intercourse. So it's a huge thing that we need to think through. I know Ghana Health Service is there. They should drive it. But the NGOs, you have power. It seems we didn't say much about, we didn't put out any figure on HIV, but in the intro or the background information, the population's 10 to 19 years, you saw that 6% of that population, 6% of the total population with HIV positive falls in that age bracket, 10 to 19. Can they live up to age 80? Will they be healthy enough to contribute to productivity in the country? Can they even have a sound mind to support their families? These are things we should ask ourselves. And unfortunately, in the year 2022 alone, the new HIV cases we had, 10% also is related to this age population in this same age bracket. So it's scary when you focus on the sexual risky adolescent sexual behavior. So please, going home, I think we have to think broadly, ponder over it, and see how best together we can help tackle this problem. Thank you.
Thank you so much, Dr. Pipra. Now, at this juncture, the final one I'll give to Dr. Ayete Levy. Yes, about what services are available, the Ghana Health Service for adolescents, in that you would go to them rather than they coming to you. Because, let me add this thing to it, there was this issue of some children in secondary school or senior high school, as we know it, who have contracted sexually transmitted diseases, HIV and AIDS to be precise. And these children, their parents are not aware of their current status. And it was through some of these 1 or 2 interventions that they go to various places for the antiretroviral drugs. Some of them are not able to go because they are scared people would get to know. So are there services like that to get to the schools and find out where confidentiality could be assured and some of these drugs can be administered to cases like that?
Thank you very much. I think next time we'll let you be a discussant because you seem to have very pertinent issues to discuss. To start with, I think a lot of policies have been initiated where adolescent and youth-friendly services are in question. I think we have tried the disaggregated approach where we have a separate corner for them, and it becomes difficult because we know that once you enter that room, we know why you are going there. So we tried a holistic approach, and then we don't belong because everybody here is an adult and we are not treated well. So we are yet to find the correct approach to deal with this problem. So we are whoopsie-whoopsie between the disaggregated versus the holistic approach, and that's what we are doing. To answer the question, every service that is offered at the regional level is actually offered at the district level, except that sometimes when we roll out an initiative, it may start at the regional capital and gradually get to the district level. It's just that previously when we collated data, we collected them at the regional level and presented them to the national level rather than finding the same data at the district level. And that's what this exercise is trying to do. Rather than collate everything from the regional level, we're now going straight to the district level to see the information at that level and work with it at that level. So that's likely the difference in terms of the services offered. We have youth-friendly services. Our healthcare providers are supposed to be adolescent and youth-friendly. Now, I say the expression supposed to be because we are humans. I think there is a big problem with the double standards as a culture. The double standard says that we frown on adolescent pregnancy or teenage pregnancy, yet we sit here and say pregnancy before 15 is as a result of rape or defilement. Bottom line, the man said it's illegal. If as a 14-year-old, I have nice enticing breasts and a very nice behind, and I walk to your room and I say all the right things, and you agree and you have sex with me, I have been raped because supposedly I am not supposed to know better. So it's high time we move away from the blame of the underage teenage people who get pregnant and target those who are impregnating them. All right, so let us move away from you are a bad girl. Obviously, I am a foolish girl. That is what it is. I am young. That is what I'm supposed to be. And move to the person who did the perpetuating. The same double standard says that we raise our boys to be conquerors, to have more than one wife, to have a wife and a side chick, to go hunting, and train our girls to keep it closed. Meanwhile, the boys are going after the same girls, so I'm confused what we are trying to achieve. So that's why he threw the question back at us and said, who is initiating who? Because we saw it in the regions. The person who is initiating the males is not the same region that the females are being initiated. So the boys know with whom are they doing the thing. And the girls know with whom are they doing the thing. Same question, we are back to that place. So it is the double standards in that area that's having the problem. So that double standard carries out all the way to the service delivery, whereby we are supposed to be youth-friendly, yet we blame them for being young and being foolish, rather than accept that this is what we have and deal with it and find out the root cause in a different way. There is also a big problem in the adolescent and sexual talk when it comes to education at any level. We have tried several ways and we have not gotten the message right. And so we have difficulty penetrating the areas to do that thing. If I walk into a school to talk about sexual education in adolescents, I am seen as introducing them to sex and making them promiscuous. Woe unto you if I add on to safe sexual behavior and cell, where I know some of you will do it anyway. So if you do wear a condom, then I am promoting the sex now. Before I was seen as possible promoter, now I'm promoting it. So I don't get access to school. Ghana Education Service will not allow me there because we made a mistake with the message the last time we tried to introduce sex into the schools, and we did some who knows booklets that brought us into problems. So Ghana Education Service is shut. At the home level, the parents don't want me there because I am also bad. So at the home level, it is shut. So I rely on peer influence groups, youth-friendly services, influencers to try and get my message across, which is passing the message through several routes and mediums. By the time it gets to the destination, it sounds completely different from where it started from and looks completely different. Recently, we did a survey in Tamale Teaching Hospital when we were trying to find out our service delivery at the Family Reproductive Health Unit. And when we called the high school JHS students, not even SHS, JHS students to talk about the sex, they know who knows how to use what. Okay, so if there's a problem, they know who to go to. They'll tell you, if you have this problem, go and see Akosia. She knows what to do. So the schools have knowledge, yet what knowledge do they have? That's where the problem comes. But I can't penetrate there. So as we are all sitting here, the question is way bigger than we think it is, and it's much, much more humongous than we are pretending it to be. Let us go back to our cultural setting and our grassroots. Raise the kind of sons you want your daughters to marry. Then we start from there. Because invariably, those same sons will take care of the daughters that you have. Because as we are sitting here, we all agree that the female sex initiation is by older men. That's the bottom line. The female sex initiation is by older men. If those men are correct men, we shouldn't be here. So if you go back to our grassroots and start from there, then I think education moves forward. If I keep talking, we'll go and go. So I think
I can see that.
I
can see that. So wrapping up, socialization is key, starting right from the home, because the first mentors we see as children growing up are our parents, our aunties, our uncles. So then we have a lot to do. An all hands on deck approach is the way to go, right from the home, right to the school, right to the churches, right to the mosque, right to the communities, and together we would make progress. Thank you so much, members of the high table. Thank you so much, our audience. Indeed, we are grateful. At this juncture, I would invite Deputy Government Statistician Dr. Faustina Frimpong Engwa to do us the honors with a brief remarks, then subsequently launch of the 2 reports. A round of applause for Dr. Engwa.
Please, can I have...
sure, they would have to join you. Yes, members of the high table, kindly join Dr. Engwa to launch the 2 thematic reports. A hand of applause for them, please.
And so, thank you, but one of the things that I would say is that GSS has given you some questions. So there are so many things that on your minds that we think that we should delve into. And so our doors are opened. We can collaborate to do more analytical so that you may know whether it's out of school. Is it telenovelas we are watching? Those things we are watching and other things that is pushing us to where we are. So we will be waiting on you so that we'll collaborate and do that more detailed analysis, the nuances, to bring out the questions that we are trying to seek answers to. On that note, I think that we want the honors on us to be able to launch the 2 reports. And so we, by the mandate vested in us, do represent the reports on the release of the small area estimation reports on utilization of maternal health care services, and again another report on adolescents' risky sexual behavior in Ghana. So, duly launched.
Okay, so let's all have it this way. Yes. Yes. So, Papa, are we good? Yeah. Okay. A round of applause. So the 2 thematic reports are duly launched. Thank you so much. Thank you so much, Deputy Government Statistician and members of the High Table. A round of applause for members of our High Table, please. All too soon, we've come to the end of today's program. Indeed, we are grateful for your time with us, staying through with us, those joining us online and all that. But to properly close us, ladies and gentlemen, with a round of applause, help me welcome the Director of Survey and Census Organization, Ghana Statistical Service, Mrs. Abena Asamoah Osei Akuto. A round of applause for her, please.
Thank you very much. If my boss was here, he would say data per day, right? So today we've been exposed to a lot of data in terms of delving to the nitty-gritties, down the localities, the districts. So please, let's make noise about the data that we've shared. We are also available. There are areas, as Dr. Ingwa mentioned, that we can collaborate with the various partners and then MDAs for us to delve into, to expose a lot of things for us, to help us also have right solutions or right policies to attend to issues that are very, very localized. Let me use that one, localized. So on that, we would want to also appreciate all who contributed in making this program possible. Those who wrote the reports, the data analysis team, the presenters, the policy analysts who helped us in analyzing the issues, then our audience from varied backgrounds. We are grateful, but even that, we also want to inform you that we are still in the field. Our mandate is to collect data and ensure that we make it available for users. So we are in the field collecting data on the Ghana Living Standard Survey. We will come to your doorstep. I don't know which of you whose household has been selected, but when we come, please open your doors to us and accept us, ensure that we get the right responses such as this. Please, and then also, since you've heard about it, please tell others. It is a survey. It is running for 12 months. We've done 3 months now. We are in the 3rd cycle. We will have 10 cycles. So should somebody knock at your door, we are coming. Please, open your door to us and be receptive. On that note, we would really say thank you to all of you, and knowing very well that we can always count on you, and especially the media, as it was mentioned. Please and please, let's channel where we want our problems to be solved in terms of discussing issues like this to ensure that we have right solutions to them. Thank you.
Thank you so much, Mrs. Abna Osei Akutu. All too soon, we've come to the end of today's program. Indeed, we are grateful for your time with us, as Madam Abna has stated earlier. We are grateful. Lunch will be served, arrived, or I think lunch has been served. So we will take a closing prayer, then we will use the door right behind us as the exit, then we'll take our right turn, and the door to the dining area will be on your right. Ladies and gentlemen, it's been nice being with you. Thank you so much for your cooperation. My name is Nat Jagbli Ago. At this juncture, I would invite Imam Abdullah Mohammed with the Ghana Statistical Service to take us home with a Muslim prayer. A round of applause for him, please.
Thank you. Almighty Allah, we thank you for all the favors that you've issued on us. We thank the Almighty Allah for giving Ghana Statistical Service Management and the project coordinator and all those that help for us to get this data being launched today. We thank Allah for that favor that He has given to us. We pray that this data should go far so that all policymakers will have access to this data and use it so that this data will be good for all of us and Mother Ghana as well. To this, we thank the Almighty Allah. And as we've all come here safely, we are also praying that God should lead us to our various houses safely as well. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الله لا إله إلا هو الحي القيوم لا تأخذه سنة ولا نوم له ما في السماوات وما في الأرض من ذا الذي يشفع عنده إلا بإذنه يعلم ما بين أيديهم وما خلفهم ولا يحيطون بشيء من علمه إلا بما شاء وسع كرسيه السماوات والأرض ولا يعود حفظهما وهو العلي العظيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين.
A round of applause for Imam Abdullah Mohammed. One last information, please. National service personnel of the GSS are being entreated to wait behind for a meeting before you go for your lunch. So kindly wait behind, national service personnel of GSS. So please, at this juncture, let's allow members of the high table to take leave of us first. Then we would continue in that order. Thank you so much.